We are live now, doctor.
Yeah. Hello and welcome everyone for today's live webinar, the special series, the Presidential Live Webinar by Glaucoma Society of India. And I'm Dr. Satyan, President Glaucoma Society of India. Today we have two eminent speakers, our past presidents, our wonderful past presidents, our beloved past presidents, Dr. GSI Das sir. He is the ex-director and professor of MAMC and the chief of glaucoma services at Shroff Eye Center, New Delhi currently. And we have Dr. Harsh Kumar ji, director glaucoma services at the Center for Sight at New Delhi. They don't really need a big introductions. They are very well known to all of us. And not only that, they've selected a fantastic topic where everybody needs to know about these two topics. One is on the gonioscopy and another is on the lasers, which is practically done by every one of us today. So first topic is going to be by Dr. Jayashidas sir on gonioscopy. Then we have at the end of the second talk, both the talks will be for 20 minutes each. And then we have wonderful panelists, Dr. Madhu Badaria. She is the director of RAO Eye Hospital, Sitapur. And we have Dr. Prafulla Sharma. He is a senior glaucoma consultant, Prime Eye Care Center from Guwahati, Assam. So without much delay, I would like to request our first speaker, Dr. Jayashidas. Over to you, sir. Das sir, you can share your screen.
Full screen. Full screen.
Full page, yeah.
Thank you, Dr. Satyan, to give me this opportunity. And in fact, this 20 minutes talk on gonioscopy is not a gonioscopy lecture. In this 20 minutes talk, I'll try to clear some of our doubts and some of the gray areas and some of the confusions in our whole gonioscopic picture. And gonioscopy is which type of gonioscopy you use? There is a lot of confusion about it, but the direct gonioscopes is just surgical gonioscopes. Keep it aside. Indirect gonioscopes are the gonioscopes you usually use for gonioscopy. 1 mirror, 2 mirror, 3 mirror, 4 mirror, and 6 mirror gonioscopes are available. But strictly 3 mirror gonioscopes are not meant primarily for the gonioscopy because this is too huge that distorts the angle. So 3 mirror is a big no for any type of gonioscopy. To say the protocols, there is one, you have to select 1 2-mirror gonioscope, the Goldman's, and 4-mirror gonioscope, what is called GSI gonioscopes. The 4-mirror gonioscopes have got a smaller contact area and doesn't need any coupling agent. You have to just anesthetize the cornea and put it over the cornea and start examining the slit lamp. On the other hand, the 2-mirror gonioscopes, like Goldman gonioscope, has a larger base area and needs a coupling agent for viewing the angle of the antechamber. But the main advantage of the 4-mirror is that you can do indentation gonioscopy, but I'll come to that indentation gonioscopy. There's a lot of confusion in indentation gonioscopy. See, there is indentation gonioscopy, manipulative gonioscopy, compression gonioscopy, and dynamic gonioscopy. They're all practically the same. Indentation gonioscopy, compression gonioscopy, and dynamic gonioscopy, they use 4 mirrors with a smaller contact area. You press it on the cornea, press at the central area. This is to see the angle forcibly. So when you press it on the central cornea, the aqueous is driven to the periphery, pushes the peripheral iris, and you can see the angle closure, whether this is a positional angle closure or this is a synechial angle closure. Then, of course, you can also see what is the extent of synechia in the angle. And the same thing, you call it as a indentation, compressive or dynamic by different authors, but the same procedure. which uses a 4-mirror gonioscope. And this is the low down the figure is the central area we are putting the 4-mirror gonioscope. On the left hand side is the angle which is closed, and little pressure the peripheral iris is open, the angle is open, and you can see all the angle structures. On the other hand, you can also use a 2-mirror gonioscope, and you can maneuver the same maneuverability, and you can press the edge of the gonioscope at the lower part. It pushes the aqueous to the upper part, again pushes the peripheral iris, opens up the angle of the antechamber, and you can assess the same type of, get the same type of information in the same procedure. This is a little modification of the technique, and this is done by 2-mirror gonioscope, and it is practiced by Gorin technique. And this gives the same information as the 4-mirror gonioscope. Many questions are whether you can sterilize it, various methods and that, but the simplest way to alcohol sponge available very easily, very cheap, and you clean it with the alcohol sponge. And the after the sponge, you see that the alcohol doesn't get into the cornea, and you should wash it with the antibiotic solution. But take care that we are not cleaning the flat surface. Don't drop the flat surface, because that is containing the anti-reflecting surface coating. When you put the gonioscope in the eye, the indirect gonioscope, you get the invert mirror, invert image. So this is the image you get, but it is not a crossed image. It is a mirror image. On the right hand side, you can see that the blood vessel at 11 o'clock represents the blood vessel at 7 o'clock. It is not 5 o'clock. The PI, which is 1 o'clock, it at 5 o'clock, not at 7 o'clock. So you get a reverse image, but it is a mirror image. It is not a crossed image. You must identify the angles very, very clearly. You must understand it. That is one thing. One is the anterior solvus line, and trabecular meshwork, scleral spot, ciliary body band, and last one the iris. All the years we have been talking about the anterior solvus line, trabecular meshwork, even scleral spot. But these two areas of ciliary body band and the last one of the iris are probably the most neglected area. We have not given enough attention to this particular area. These arrows will show that the anterior solvus line, then trabecular meshwork, then the scleral spot, ciliary body band, and the root of the iris. This is how you identify the anterior solvus line. And when you focus it, you focus a narrow beam with brightest light, and narrow beam have got two definite lines. One is reflected from the corneal anterior surface, one is from the posterior surface. When these two reflecting lines join, that is the end of the Descemet's membrane, and that is the beginning of the trabecular meshwork, and that is anterior solvus line. This is how we differentiate in the upper part. If you do the gonioscopic mirror from the upper angle, that means you are viewing the lower angle, and this is the picture second to it. Is showing the corneal wedge in the upper angle. So far, we have been grading the angles, and the most commonly followed angle is the Cephas classification, which according to whatever the structures you see, you grade it as 4, 3, 2, 1, and 0. So accordingly to the Cephas classification, you see that is open angle, seeing all the structures, and the narrow angle, you can see only a part of it, and trabecular meshwork, maybe 1/3 of trabecular meshwork, and of course closed is no angle structures can be visible. But this classification is not sufficient. Want to add 3 more parameters from the Smith grading classification to this present Cephas classification. One is the insertion of the iris root. It may be at different places, at 5 different places. I'll come to that later. And the angular width of the angular recess. This point needs little more clarification. I'll come to it later. And the configuration of the peripheral iris. This is the 3 parameters we are including. One is the insertion of the iris root. Second is the angular width of the angular recess. And third one is the configuration of the peripheral iris. I'll use some of the schematic diagrams. See, this is the insertion of the iris root and anterior solvus line. See, this is behind the solvus line. on the scleral spur, behind the scleral spur, and on the ciliary body. You must identify where exactly the insertion of the iris root is. This is the first insertion, first parameter you must include. Second parameter is the angular width of the angular recess. This is again, the angular width may be 40 degrees, 30 degrees, 20 degrees, 10 degrees, or even slit line. This point I will clarify again what exactly angular recess and what exactly we mean by angular width. Second parameter is the angular width is like this, 40, there's 20 and 10, and the third parameter we are including is the configuration of the peripheral iris. Configuration may be queer, that means this is concave posteriorly, or it may be regular, or it may be stiff. So iris configuration may be of these types. You must note it that the peripheral iris configuration is stiff or is regular or is square type. But the most confusing and most ill understood aspect of the configuration of the peripheral iris is the plateau iris configuration. This is probably creating all the misunderstandings, all the misinformation, and clinical in the difficulty in the clinical assessment. Plateau iris configuration means the iris in the central area is flat, but it takes a sudden bend with an angle to take its attachment to the ciliary body. This iris configuration, the plateau iris with a sudden bend to the angle, that is creating little problem. Clinically, what you see is a double hump pattern of the iris and in the plateau iris. The peripheral hump, the hump is because of the ciliary body, which is pushing the iris forwards. And the inner one, towards the center, is another hump, which is because of the lens. This two hump iris pattern is pathognomonic of the plateau iris. This is all clinically. But the thing is, there is a very narrow difference between where exactly the iris is going to attach in case it is dilated. You see the lateral wall or the wall of the angle has got the solvus line and the trabecular meshwork, which is divided into the non-pigmented area and pigmented area. Then there's an area of scleral spur and of course the ciliary body band. And this is the situation. So this is first situation. Say for example, in case you dilate it, this will strike over here in the Slem's line, the anterior line, and the rest of the structures, these structures all be occluded. That means this is a complete iris, the plateau iris, and this will give rise to the intraocular pressure rise sooner or later, whether you are dilating it or it is spontaneously dilated because of some other reason. So this is one situation. Second position is in the trabecular meshwork in the non-pigmented area. So if we dilate it and the iris will be touching this area, again blocking all the drainage areas. So this is also a complete plateau iris, which will again reflect in the rise of intraocular pressure. Let us see the third position. Third position, it is the pigmented epithelial area. The pigmented epithelium area is a larger area, and depending on where exactly the iris is touching, suppose this iris is dilated and is coming nearer, and is trabecular meshwork pigmented area, this part, so some part of trabecular meshwork pigmented area is still free, so intraocular pressure may or may not rise. That is the third position. Let us talk about the fourth position, where the iris after dilatation is touching the scleral spur and drainage areas are open, so it is not likely to increase the intraocular pressure. This is a low plateau iris collitas. So coming to the point again, that what is angular recess, what is angular recess area, and what is angular width of the angular recess. Just to give the photograph, the ASOCT photograph, you can see this is the mental impression you take, that this is the angular recess. This is the iris surface. This is the scleral spur. and this is the angular recess. UBM picture, you can see the angular recess. The trabecular meshwork is here, the anterior solvus line is here, but this is the recess. So the recess is very important as far as the plateau iris is concerned. This is the angular recess area. Angular recess area, this was angle is, the recess is here, but the recess area is 750 microns away or even 500 microns away. And this is a pictorial presentation that this is the angular recess area. This is where the confusion is there. This is a wide, narrow, or slit-like or closed. This is not this angle. This is not this angle we are talking about. This is the angular approach to the recess. The angular approach to the recess. That means this angle is not here. This angle should be somewhere here in the recess area. If I show you the diagrams, this is the angle which is 20 to 40 degrees. The recess is open. This is narrow, it is 20 degrees, and this is 10 degrees angular, the angular width of the angular recess, and this is closed 0. Right? So this is the angular width of the angular recess. There are other confusions like iris processes, sparse, and gonosynicas, but I won't take much time on this. The only thing, iris processes are normal. They conform to the configuration or concavity of the angle, and they're not pathological. Sparse is always pathological, and they're attached to the trabecular meshwork or beyond. And gonosynicas are small attachments in the trabecular meshwork only, and they indicate that there is earlier acute attacks. Little confusion about the degree of pigmentation. You can see degree of pigmentation. This is 0 degree, 1, 2, 3, and 4 degrees of pigmentation. You must depict it in a Becker's goniogram. This is for future references, and you must stick to it. All these years and all these times, we have been talking about the iris and its position to the wall. Wall means which contains all the vital structures, sorbus line, trabecular meshwork, sclerospore, ciliary body band, iris, everything. So what happens to this area if the eye is normal? In a myopic eye, in a ophthalmic eye, when the eye is too large, myopic eye is a larger eye, a normal eye, or in a hypermetropic eye, or in an ophthalmic eye. That means in an ophthalmic eye, this particular area, which is the main source of drainage, is squeezed or it is compressed to some extent. And in the ophthalmic eye, it is very large. So structurally and functionally, this should be something very different. This eye, normal eye, and in ophthalmic eye or ophthalmic eye may not be same as far as functionality or even structure is concerned. So now, fortunately, we have been able to vertically measure the weight, because till now we have not been able to really measure the morphology. Now we have been able to measure the vertical width of the angle, and open angle glaucoma, it is nearly 811 micrometers, and in closed angle it is 573. And now we have been able to scale in vivo measurements of the TM morphology, Slem's canal, collector channels, and even intrascleral channels. But even then, gonioscopy has got its own limitations. It is just a subjective and will give surface of the view of the surface of the trabecular meshwork. It doesn't provide any information about the angle wall morphology, but angle closure over 180 degrees could be detected only in nearly 45 to 50% of cases. That means another 50%, with the best of our effort, we won't be able to identify the angle closure at 180 degrees. And out of that, if we increase our ability, we use the anti-segment OCT, and we'll be able to detect 66% of angle closure. Not even 40% is still undetected, if best of possible armamentarium we have at our disposal. And 10% of the patients who are diagnosed as angle closure and open angle glaucoma on gonioscopy may actually the angle closure patients. Thank you very much. Any question, I'll be delighted to answer.
Yes, sir. That's a wonderful talk, sir. Very precise. And what is that we really need in our clinical day-to-day practice? One has to practice in gonioscopy. Excellent talk, sir. I hope that more people will see in our YouTube link. Thank you, sir. We'll just wait for Dr. Harsh Kumar ji to have his talk. And then once both the talks are over, we will have our discussion. Dr. Harsh Kumar, please. Yeah.
So are we good?
Yes. Thank you. We can see your slides and we can hear your voice as well.
All right. Thank you very much, Dr. Satyan, for having me here. And it's a great opportunity to address the entire GSI. And what we basically are talking about is the laser treatment for glaucoma. And what I basically, like Dr. Das also clearly explained what was his aim. My aim primarily is for all the youngsters to be able to understand that it is not always what is written in the books or in the journals that is important. You see the need of the patient and then think out of the box. And that is how some of the most beautiful procedures are born. So I'll show you 2 or 3 of them and just cover a little bit of the rest of the lasers. So Dr. Das has so beautifully explained the angle. Now here is a classical iris Bombay, and we know that the most common procedure that we perform is the peripheral iridotomy, and it is commonly performed obviously for an iris Bombay or a pupillary block. So classically it is given in angle closure if it is an acute attack, primary angle closure, fellow eyes. If a secondary glaucoma is having an iris Bombay, yes, it is a beautiful procedure. But for PACS, it is another matter. The number of PACS in India and the world over are very, very high. Sir has explained exactly how you differentiate, so we'll not go over there. The basic fact is that after the ZAP and the Singapore trials, the number needed to treat is quite high. So in ZAP trial, it was 44, and in Singapore trial, 22. So these many patients must be done in LPI so that one patient will be prevented from going into a primary angle closure or PACG or an acute attack. So thinking that, one has to understand that if you are going to do a PI in a PACS, first please check, is there a family history of angle closure? Is the patient one-eyed? Will he need repeated dilatations? Is there a history of IOP elevation like evening headaches or halos? Or the patient is likely to be lost to follow-up. So all its PAC, its fellow eye of acute, like we have already said, have to be done. But for the rest, you can actually discuss with the patient that, all right, I need to do this because the angle seems very narrow. But if you are able to come regularly to me for follow-up, then yes, we can also follow you up. So you have to get, and the advantages of doing it and not doing it have to be explained and discussed with the patient before you go ahead and do it, because so many patients, they'll actually have a problem. And the moment you do a peripheral iridotomy, many of our patients have thick irides. So the pigment will be released, gone into the angles, and the pressures will become high. So you have to be very, very careful what we are dealing with. What about the chronic angle closure? Now in chronic angle closure, again, if there's an element in which there's a bit of a pupillary block, yes, it is going to help. But otherwise, if the angle is already closed up, then you are actually going to worsen it by increasing the pigment release. A very interesting fact is a patient who's plus minus controlled with a peripheral iridotomy on and medications. So we did a paper with Professor Sood, which showed that if some of the angles are open and you find that even in this chronic angle closure, then you do an iridoplasty all around 360 degrees. And then a lot of these patients can be well controlled. A 3 to 4 millimeter lowering can be achieved for quite some time. Many a times I get a phone call, sir, how much energy to use? The hard fact is, if you have a new laser, you can go through very easily. If it's an old laser, you'll need more. Try and aim for 3 to 4 shots. If you're going through in one shot, then you may even create a subluxation. If you are going to take too many shots, then you're just chipping the iris and the pigments get all spread out in the anterior chamber and you won't be able to get through in that. And for God's sake, don't tell them that it's a 2-minute job. The day you say it's a 2-minute job, you won't be able to get through. Where to do it? Well, as far as the sites are concerned, classically now you can do anywhere. If you can find a crypt, wherever there is a deep thing and it's easy for you to do, go ahead and do it away from the arcus and the pannus, and don't go too much in the periphery. Again, if there's a thick iris that we have, especially in Indian eyes, we created a technique in which is known as a drumhead pattern technique, in which you give a large spot of around 300 microns with 300 milliwatts, any coagulative laser, argon, etc. And if you do it all around, you create a drumhead. So the central area is totally stretched out. And the moment you give a YAG spot in the center, it immediately opens up. So this is a technique to be remembered in thick iridis with too much pigment where we are in trouble. Again, if the iris is small and you don't want to go into the PI, then what you can do is you can take an argon and put a spot on either side. And once you do that, the spot actually enlarges. The PI actually enlarges. And while we were doing one of these cases, we suddenly realized that if the spot actually comes somewhere in this area, then the PI actually got narrowed and we were so worried. But this gave rise to something now which I am going to share with you. So we know that for last 70 years, a peripheral iridotomy is known, and dysphotopsias, shadows, ghost images, lines, so many things can occur. And it has been known for so long, and yet no cure was ever found for that. So with the mistake that we did over there in putting a spot at the tip and narrowing it up, we suddenly realized, because this patient came to me and he was in complete disarray, and he said, sir, I cannot do my profession, which is photography. I just cannot go ahead and do it because of the peripheral iridotomy. Do something. We tried tinted contact lenses, we tried other things, didn't work. And then suddenly realized that, yes, if we put a spot on one side over here, then this thing is definitely going to get narrowed and possibly it will prevent. And that is what happened in this patient, that when we put a spot on this side, as you can see in this, the iris, the PI actually narrowed down. And that was really a wonderful experience. And the patient was so thankful. As you can see over here, the narrowing. But remember that in such cases, please don't be away from the pupil, because otherwise the pupil will get enlarged in a particular fashion, and that will be trouble. So this paper was just published in this March issue of Indian Journal of Ophthalmology in the innovative sections. Again, a very interesting thing, we just recorded a silicon oil induced glaucoma, a new mechanism. What basically happened was that a RD was there and they did a surgery. In the detachment surgery, the oil was filled up, and what now happened was the oil was blocking the area of the iris and the lens, and the aqueous was trapped right in the periphery, just pushing the iris forward. Now, obviously, if you take the silicone oil, all the trouble will be away, because the pressures were very, very high and was already a glaucoma patient, a one-eyed glaucoma patient. So in this kind of a situation, now, if you do a peripheral iridotomy here, nothing happens, because there's silicone oil over here and the aqueous is pushed right to the periphery. So my detached with this friend told me that please do a peripheral iridotomy in this place. And I was really zapped, then how the hell can you do it in this place? But since there was no alternative, we tried, and this is how this procedure was born, that first you go ahead and put a very small spot of 2 millijoules that actually pushes the iris back, go to 4 millijoules and then 6 millijoules, and then suddenly you'll find that an iridotomy is created. And once that has happened, even with that narrow recess, the entrapped aqueous came forward and the pressure was released. And this was again published for us. One of the very important procedures which is not being so commonly carried out is gonioplasty. Now, what basically it means is that you put a large spot of 300 to 500 microns on the iris with a low power of 0.2 to 0.3 watts. When you do this, you are just charring the superficial iris. So I showed you that some of the spots previously in the drum head pattern technique. So everywhere we are using this. The idea is if there's a pigment release, that means your power is too high or the spot is too short. So you increase the size of the spot or you decrease the power of the laser. And then what you want to achieve is the charring so that the angles opens up. Or like I showed you just now, how a peripheral iridotomy can be narrowed up. So these are the type of spots, but gonioplasty is indeed a wonderful technique. You can use it with a gonio lens or you can just do it directly. The idea is to keep one spot width between the two spots. So you can do it directly like this, or you can actually use a gonio lens and put it around 1 millimeter away from the root of the iris. So the sir has already showed beautifully what a plateau iris looks, and that is the primary place where we use the iridoplasty. But and usually what happens in plateau iris, you'll have to do a peripheral iridotomy, and then you realize despite that, the angle is closing up, and then we use the gonioplasty. Very, very important thing is that many patients come to us with angle closure glaucoma, very high pressures, you can't get through, cornea is edematous, the pressure is not coming down despite mannitol. And that was the time that I suddenly remembered that Dr. Lamb and Rich had already told of a procedure that gonioplasty can be tried in this. So many people ask me, sir, how will the laser go through? My answer is just go and do it, and it will indeed go through this. So any coagulative laser, you put 360 degrees around and immediately you see that the angle opens up, the pressure lowers out, cornea clears, and then you can complete your iridotomy. And this is just an image sent by my student who said that we tried it so beautifully in this angle closure where it opened up and was such a relief for us. Even in cases where there's a block at the lens and you cannot take patient for surgery, you can try this. Topiramate-induced glaucoma, again, if there's an acute elevation which does not settle down with anything else and you are waiting, stopping the drug, giving atropine, etc., you can try this out. And there are papers telling about this. Now, this is another procedure that we thought a one-eyed patient who came with dysesthesia, hypotony, macular edema, and we all know that there's an excess fluid going in, which should ideally open it up and close up the thing, but the patient was just not ready to go into the OT. So what we did was we painted it with gentian violet, and then we gave spots just exactly like I told you. And so we just put a couple of spots in both the sides to char it out and prevent the fluid from going below further. And the entire fluid was then absorbed and the choroids were all healed out. So this again was published long time back. Similarly, if you have an overhanging bleb or very large bleb, you can give sutures, but again, it's an OT procedure. Short of that, you can again paint it up with gentian violet and give the spots as we already told. Now, this is a procedure. So again, it is the need of the patient, like the peripheral iridotomy, narrowing, which I showed you, was the need of the patient. This one-eyed lady, the other I lost during surgery, a case of uveitis, high pressures, posterior subcapsular cataract, completely refusing the surgery. Multiple peripheral iridotomies are failing, as we all know, in cases of uveitis. In these cases, so I thought what to do, and we suddenly came up with a procedure in which we dilated the pupil and we start hitting the synechiae with very low power of 0.5 millijoules. So you go from inferiorly to superior in either quadrant. Multiple sittings will be required. There will be hemorrhages, but ultimately you end up with a procedure like you end up with a situation like this. And the patient was so relieved because the cataract was bypassed and the fluid uh, came out from here, and we were able to overcome both the problems, and such a beautiful feeling. So one can and definitely may try these procedures without any hitch. A simple thing is a suturolysis, but so many times it is required. I know most of us give releasable sutures, but many a time the releasable sutures break. And then what you can do is just blanch the conjunctiva with tropicamide and then put in a lens. You can even put a gonioscope, and then you can just visualize, cut with a 50 micron spot size, 0.1 second, zero 0.6 to 0.9 watt. You can use any coagulative laser with a Hoskins lens, and you can see that the suture is cut, and the moment you press a little bit, you'll have a beautiful plug. DLCP or diode laser cyclophotocoagulation was essentially tried basically for cases which have completely failed. But basically for penetrating keratoplasty, post-traumatic glaucoma, so many other glaucomas where other surgeries have been tried but have not succeeded, and there's nothing more to do. But now of late things have changed, and people are now doing the DLCP primarily for even seeing eyes, and we have seen some good results. So if you do it in a graded fashion, sometimes the results are nice. One important thing is that you must do transscleral transillumination to actually demonstrate what is the site and the position of the ciliary body with a small pen torch in a completely dark room. And then you can realize where you have to actually put your laser. Obviously, you have to explain to the patient that there can be phthisis, vitreous hemorrhage, painful eye, and so many other problems. But once the patient understands, you can surely go ahead and do the procedure. A new type of micropulse laser had come, a new type of diode laser, Cyclo G6. And basically, the idea was that it was much less destructive than DLCP or the TSCP that we call, because of the off time of the laser. And the problem was that the company touted it as instead of doing trab, you can do this. It works well in some for a long time, but many need repeat. Additional surgery may be required, but the problem is that you have to explain to the patient you can have hypotony, failure to reduce pressure, pupillary dilatation, bleeds, and RDs are all seen by us in micropulse laser. SLT, again, introduced way back, is being tried in our country, and it is a very simple procedure, easily performed, can be repeated. Excellent results in the West, but it's a mixed bag for us. But obviously, if you have the machine, the patient is open angle glaucoma, you explained the prognosis, treatment naive patients or patient with side effect of drugs can definitely be taken up as the first procedure before you go ahead on medication. So please use everything with caution, get all aspects of procedure, don't love or hate it. Just use it science. Don't believe in all the publications, look at all, judge yourself, and please think out of the box. This is our review article in the Indian Journal of Ophthalmology. Thank you very much for your kind attention.
Thank you so much, SG. I think you must take some little bit of water.
Yeah.
A wonderful talk with all practical points to take home. Again, I hope many people, whoever has seen, will be really very, very useful take-home tips. And as it is going to be available in our YouTube channel, please do visit the YouTube channel to listen to both the topics. Now we have our panelists and the moderators. And today we are going to just invite our secretary, Dr. Manish, and our treasurer, Dr. Deven, also to join in our discussion. Over to you, Dr. Prafulla and Madam, both of you. Yeah.
Thank you,
So,
Satyan.
Yeah.
Yes, Dr. Modu, please.
Yeah,
no,
both
go ahead.
both of you. Yeah.
I think Dr. Das has very vividly described everything about gonioscopy. But two basic things, actually, I'd like to inform us or enlighten the viewers, because many of the general ophthalmologists and procedure students are there in this, I think, webinar, seeing this webinar. Sir, how should you often do gonioscopy in our routine clinical practice? That is one. Secondly, which gonioscopes are you recommend for the beginners? Because you know that many ophthalmologists, they do not do gonioscopy in their practice. If they want to start gonioscopy, which gonioscope they should buy and practice first? Very basic things are we like.
In my practice, I do gonioscopy practically for every patient who is coming with a glaucoma problem to me, or if I feel that the pressure at any point of time has been high, or the chamber is borderline, and I do it immediately for all the patients. I use a 2-mirror gonioscope, Goldman 2-mirror, and on very special occasions, I found it is better than the 4-mirror in this sense. This is my experience. I've been using gonioscope for last 50 years. So in cases where the patient has got the nystagmus, patient is not very cooperative, the patient age group of 8 to 15 or 12 or 15, those children are not very cooperative. Or in case I want to see in the angle something very, very initial stage like neovascular glaucoma, and if I want to see a very thin membrane which is occluding the angle, I need the stability of the eye, and I need the 2-mirror gonioscope is more handy than the 4-mirror gonioscope. And in cases of small fragments of, say, pseudoexfoliation, and where I need to focus a little more carefully, I think I'll certainly prefer a 2-mirror than the 4-mirror. 2-mirror, after using for so many years, I know how much pressure I have to give and how lightly I can examine the angle. So otherwise, I prefer in special situations like this, a 2-mirror over 4-mirror. I have got 4-mirror with me, I have got 2-mirror with me. So I always prefer in difficult situations like this, the 2-mirrors.
Yes, sir. Dr. Modu, please.
So, Harsh always gives such clear-cut talks. It's very difficult to pull out the questions out of his questions for him, because he makes really things very clear for the audience. But all that, Harsh, you have such a tremendous experience. And PI is something that needs to be done a lot more. But why do you think people are not really doing gonioscopy? What is kind of hampering this? And is YAG freely available? And it doesn't need actually whatever technique to learn it. But why is it so that so many of patients of POAG are being treated as PSCG are being treated as POAG?
So, madam, this is, I think, very nicely brought out. To be very, very frank, we keep hyping the gonioscopy, but I've seen so many times the top people in the country having absolutely different opinions on their own gonioscopies. So I think gonioscopy is definitely a very, very difficult art. It's not easy at all. But yes, you have to keep doing it till you get to it. The problem is that nobody today is really, I think, either they are sitting in a very busy practice and they don't find time to do it, or there's no inclination to do it. Though we keep teaching that if you don't do it, so I tell them, if you don't do it, somebody else will do it and do a peripheral iridotomy and earn money through that. Plus, the patient will say, oh yeah, this fellow did not even know that. So every practitioner, ideally, for any glaucoma patient has, like Dr. Sir said, has to do a gonioscopy, because not only for the fact that you're doing a iridotomy or not, but the simple fact is that all angle closure have a 3 times more chance of going blind as compared to an open angle. So that I think is critical.
point I really wanted to bring out, because and second thing is when the patients coming so often with one eye blind and other eye having normal pressure or little high pressure. These are the other eyes where laser is absolutely mandatory, because PSCG in our country is so many instances is so unequal in two eyes. It's not like a POAT, it's very, very unequal. And second question I have Harsh for you, that you have used, like even I also use DLCP and the pulsed. What advantage do you find with pulse? I was very happy with DLCP. I have a pulse now, but there isn't really anything much worth wasting so much of money over DLCP.
Absolutely, absolutely, ma'am. Over the time, people have realized this. And I was talking to some of my friends in institute and other places, and I think most of us have given up doing the micropulse. But those who have bought the machine are forced to keep doing it. But frankly speaking, there's no big, you're absolutely right. There's no big advantage of one over the other.
Because DLCP was my very favorite procedure for all those, you remember that time in Delhi.
Yes, yes,
And
yes.
now with micropulse, I'm not seeing any advantage. On the contrary, the patients have to make a few more trips. And that is not helping. Though I haven't seen any thysis or really hypotony so far, but other things are as much.
No, no, we have seen detachments, we have seen hypotony, we have seen full
Thysis
bleed.
I've not seen, but rest is fine. Rest is fine.
And another thing regarding this influence more and more people to do gonioscopy, I think the best place is the residency courses. During post-graduation, if the medical colleges, they encourage these post-graduate students to do gonioscopy, because that is the best place, because they get a lot of patients. I think if from the beginning, they start doing gonioscopy, because they get a lot of scholarship nowadays. So I think it should be mandatory that every postgraduate students, they should have a gonioscope and they should practice it. Unless they do it from the beginning, I think many people, they hesitate to do it afterwards. That is my experience.
The problem is,
Prafulla, have you seen government medical colleges? The teachers do not know how to do it. I'm so sorry to say it, but the problem is more than residents. The problem is with teachers. We've got to focus in GSI. We have been focusing. I'm so sorry. My teachers and all will kill me. But
That's correct, madam. Correct, madam. That scenario has to change.
we need to have teachers training program in GSI things specifically focused on them, because teachers are neither paid very well nor anybody looks after them. So somewhere down the line, it's pertinent to bring out that these issues should be dealt with by
Yeah,
GSI.
we will have more of that discussion. We'll just try to focus on Manish. Do you have anything to say on both the procedures? Yeah, laser
So
peak,
I would like to,
and then you can, yeah.
So I would like to congratulate both the speakers, excellent talks, and Dr. Das has brought out so many points. And what I would like to stress on is that when we are examining a patient with a narrow angle, as we see the gonioscopy, how can we guide the newcomers or the people who are learning to evaluate for the lens factor? Sir has shown very nice photograph of the double hump that you see with the plateau iris. But I would like to bring out the point that even there are many narrow angles which are the responsible for the lens and increased lens volt. And this can be evaluated quite well with a UBM, but we can evaluate with the gonioscope also. Sir, you would like to elaborate on that?
First thing is that what the mind doesn't know, eyes can't see. So we must keep that thing in mind and must relook our gonioscopy. Let us start afresh the gonioscopy with little modification to it. Give special attention to, especially in Indian situations, two things in the gonioscope. One is the ciliary body band, and the other one is the last roll of the iris. That is complicating the whole issue of plateau iris. And ciliary body band is the unconventional area of drainage, and that is the site in which the supracortical drainage procedures can be done. And in presence of the anterior location of the ciliary body, or even anterior attachment of the iris to the ciliary body, the complicated area is this ciliary body area. We have never bothered about that thing so far. So we will have a renewed effort to see that the ciliary body area is not a part of the normal gonioscopy. One has to include that part in the gonioscopy and stress in our future talks that the ciliary body area and the last roll of the iris, which is attached to the ciliary body, are of prime importance as far as angle closure in Indian scenario is acceptable. That is two things I must tell you that we must do it. And if you are doing it fresh, so let us add three more parameters of Smith classification to this most commonly used Shepherd's classification.
Dr. Satyan, can I ask?
Yeah, please go ahead, Devan.
So I think there's been all report in different parts of India about SLT. And I know from experience, having heard Professor Das and Dr. Harsh Kumar in the past, uh, Das sir has done studies on SLT and he's not much in favor in Indian eyes. And Dr. Harsh earlier used to say no, but I think now he has a mixed kind of opinion about it. So let me ask the other panelists, starting with Dr. Satyan. Satyan, I think you've done some studies while you were at Arvind.
Yes, Devan, we had about inclusion was about 800 eyes, which we have done. And of course, I'm out from Arvind system, but I can share our initial report for an year or so. So the initial report in open angles, because the time age group was also like 40, and we have included pseudo exfoliation and pigment was also there. The only thing what we've seen is the treatment naive patients, they do respond very well. One thing. Second thing, if the pigmentation of the patient is little on the higher side, the IOPs may have a spike. That is about 10% of them had a IOP spike. So what you need to do is you got to reduce your power settings. And third is like when you have the patient below 40 years of age group, try not to do the SLT because they respond in a very different way where they may go for a very high IOPs. So select those with above 50 years, little less pigmentation, and above the age of 50 years, they do respond very well, and the treatment name will definitely respond very well. So that was been our result, and recently I think the Arvind team again who had a follow-up of the patients
Ganesh, I think, has presented this.
Had a good response rate. So if you really look at our own study, the success between the medication group versus the SLT group, the SLT group had a 10% extra success rate in comparison to the medication group. And also, if you really look at the studies also, again, our study also was the same. The progression of glaucoma in comparison to the medication group was little lesser in comparison to the medication group. So the idea is if you don't have too much of a fluctuation, in patients with medication group, they may have a fluctuation. It may be because of their poor compliance or the drug may not be really too effective. So both can be a possibility in the fluctuation, which may be the cause for the progression. But in the SLT group, the progression was also lesser and the fluctuations were also lesser. So when I'm saying this, it has to be little taken with the caution. Is that every patient responds? But that is the purpose of the topic today. Dr. J.C. Das sir has beautifully pointed out how you really look at the angle. If you are not looking at the angle properly, and if you are not identifying the trabecular meshwork properly, and if you think the pigmented Swalby's line is going to be the trabecular meshwork, and if you shoot the laser over there, then you will not really have the good response rates.
I think the anterior or the posterior
Endoscopy
placement
is an absolute necessity. Yashidas sir has pointed out so beautifully with so many good slides. And also Dr. has given a lot of inputs on the laser procedures, multiple laser procedures. So I think as both the speakers are there to take up more questions, we can go over them, and then we can discuss more questions with that.
Brought out a very nice point about lens vault. So if a patient post PI does not respond, maybe it's worth doing a proper ASOCT to see the role of lens vault, because gonioscopy takes a lot of time to master and see these fine points. But unfortunately, ASOCT is more easily available, because lens vault makes a very important parameter also when you choose early cataract surgery. Not a clear lens, I'm not the one for, but it's so much better to do early cataract surgery in people who have the very high lens vault.
Can we detect the by the routine practitioner is having that A scan? Does that give the lens thickness?
Absolutely.
LT it gives, but vault it doesn't give.
Then why not we do make it a
Yes.
why don't we any of like, I think, thank you very much for bringing this point out. I think we should tell all our students to do this as a part of workup. They are doing OCT.
Basically, our regular A scan, either by the touch or by non-contact, the optical biometry, both can give us a fantastic the lens thickness and the reasonable amount of lens vault.
Yeah.
So that can be really used to see, and that can be a good clue for us to understand how much is the
role of
role of lens.
So even the IOL masters are
Anything
all,
more than
everyone is doing
4.5 millimeters in thickness could possibly a potential cause for an angle closure.
Absolutely.
But I think every clinic now
They
has
should-
IOL master. It's
No, but
easy
we are
to
not.
do.
We have not told them to use it. We have never
Right.
thought of that. Well, we all know that, but I don't think we have pushed it anywhere.
Harshji, just a simple question to you on when you are using your YAG laser.
Right.
I'm not sure whether you have both the Indian version and also the imported machines, MNCs. Do you find anything different in these two machines, and what could be the possible caution that you feel that one has to practice in case if if you have been used both the lasers?
Yeah. Well, there is one center where I went and there was an Indian machine. The problem was that the shots were very, very strong. So the trouble is that you really can't try it out, but I think one should try them out on a black paper first before you are hitting the actual tissues. So that gives you an idea. If you're going to a new laser, please always try with a black paper how strong that laser is, what kind of shots it's giving.
So why this particular question was,
I'm using both
many
of
of
them.
us,
The shots are not calibrated properly in the Indian lasers. Sometimes they are very strong, sometimes they are actually very low. So therefore, there needs a lot of experience. And in beginners' hands, I would always say give a better laser, because it can just come like that. It's not calibrated, it's not persistently high. If persistent high, then we know it, we will, like instead of 3 millijoules or 4 millijoules, we can put it to 1. And another advice is we don't use pulsed in those, because we do not know 2 pulses can actually do a lot more damage instead of 1 pulse. So try with 1 pulse, and then like once calibrated properly, one is used to it, then use 2 pulsed.
okay, the simple reason why I asked this particular question was both the machines, they work in a very different principle, because one uses the super Gaussian mode, other uses the Gaussian curve, especially the MNCs. So if you really see that, you can increase the laser rate by something like a rheostat, 1.1, 1.2, 1.3, something like that. You can constantly keep increasing the laser power. But once you use the Indian laser, especially the one which uses the super Gaussian mode, it is actually 1, 2, 3, 4, something like that.
Yes.
So that is the reason why you see that the power delivery in a super Gaussian mode is excessive in comparison to the Gaussian curve lasers. And also when the tube is not fully activated, sometimes the tube may not get fully activated. So that is where you get the pulse energy is going to be little lesser. So what you need is just switch off the machine, just wait for a few minutes, and then again switch on. Once the laser is getting fully activated, the tube gets activated, or sometimes the tube may be kind of at the end of their life. So that can also be the cause. So these are some of the things I thought which is going to be a little useful for the
Really
users.
nice.
So both the lasers can be quite useful, but only thing is when you are using the
Dr.
laser,
Satyan, one point I would like to
please,
mention.
please.
I realized the difference between the two machines. When I tried to polish the anterior surface of the lens, where a lot of deposits, the thin membrane is lying on the surface of the IOL. So in one machine, I used 0.7, 0.8, or even 0.9 millijoule, and it was cleared very, and we have to change it a little bit, maybe 0.8, maybe 1, 0.9. The other machine I used the same, and nothing happened. And in some areas, it cracked the lens. So I realized that the machines from abroad, few of them, I'm not telling the brand, but the calibration is certainly much better than our Indian machines. We will certainly like to promote our own machines, but this has got some limitation. We have not come to that stage because I landed with some cracks in the lens, and it was not that in that low level. The calibration is probably a little faulty.
Thank you, sir. Thank you so much. And I think it is time for us. I'm sure that these two topics we can endlessly discuss for probably even for a couple of days. So I really thank each one of you for participating in today's webinar. A special thanks to our past presidents, Dr. J.C. Das sir and Dr. Haskumar ji. Such a wonderful personalities and a wonderful topics from both of you. I hope a lot of people do watch this program probably today or tomorrow. It is available in our YouTube. So thank you so much once again, and good night to every one of you. Thank you so much.
Thank you, Dr. Satyan.
Bye.
Thank you. Thank you, everybody.
Bye.
Thank you.
Good night.
Bye.
Good
Good
night.
night.